Hello, good morning, students.
Hello. Good morning, students.
I think, are you all able to see the video?
Good morning, students.
Are you all able to see the video?
Good morning, students.
I'll just wait for the picture to come online.
Are you able to see the video? Good morning, students.
I'll just wait for the picture to come online. Hello. All right. So I can see the video now. Is the audio visible? Is the audio accessible to you?
I can see the video.
All right. I'll just switch off my feed because there's an audio interference. Right, so let's just launch into the class. Yesterday, you all had a a gross anatomy class from abdomen and pelvis for portal vein. And that item, that big vessel, is a very important structure, taking all the absorbed food and the splenic blood straight to the liver first for metabolism before it enters into the remaining venous circulation back to the heart. We have probably in yesterday's class, you have already seen that there are several areas or locations where the tissue drains venous blood in two directions, one into the portal venous system and two into the systemic venous system, which is the what we call the caval system, because it consists of blood returning either to the superior vena cava or to the inferior vena cava. Now, in case of any high pressure situation in that area of drainage, for whatever reason, these anastomosis will open up. And since they are normally very thin walled situations and low pressure systems, an opening up of that can lead to a possible bleed if that area is damaged, rubbed against, or excoriated, or hurt, or even otherwise, simply out of the thinness of the wall, it can happen that a surge of high blood pressure would snap those very thin vessels and cause a bleed. Now, this becomes a very important clinical event or an eventuality of that happening. Now, that event happening is a solution to the problem of portal hypertension. It is the body trying to find a way to reduce the pressure in the portal system, but it may lead to another problem rising out of it. So let's see how that happens, where it happens, and what we can do about it. This you must have seen yesterday, the typical arrangement of the portal vein tributaries. So we know it's about an 8 centimeter long vein formed by the superior mesenteric joining the splenic vein. This is all happening behind the pancreas, and it's also taking the remaining tributaries, one from the gastric system, left and right gastric veins, to the paraumbilical veins, which are not shown in this diagram. We'll come to that. A cystic vein, which is a tributary to the right branch of the portal vein. This actually should be superior pancreaticoduodenal vein, this one. It could be the entire, a single superior pancreaticoduodenal, but mostly it is a posterior superior pancreaticoduodenal vein, which can be considered a direct tributary to the commencement of the portal vein. Sometimes it's a tributary to the superior mesenteric. There are a few variations which become important clinically only if there is a problem in the drainage. Otherwise, this is a silent, very sophisticated, very efficient system which continuously deals with the food you eat and with the entire circulating blood which goes through the spleen, takes both of that and delivers it to the liver. Now, the variations you need to know, which might have been touched upon yesterday, but I'll just touch upon it for the time being. There is a left gastric vein, right? and that is supposed to enter into the portal vein. It may enter at the junction rather than a little higher up. Usually it enters here, right? The right gastric and then the left gastric together. But the left gastric may enter a little lower down. It may enter the splenic vein. The stomach is here, right? So this lesser curvature will be right and the greater curvature will be left. So the left gastric coming from greater curvature might straight away come and become a tributary to the splenic vein. Then the inferior mesenteric vein, which is supposed to be a tributary to the splenic here and here, can instead become a tributary to the superior mesenteric. It does not matter as long as the blood finally comes back to the liver. But this variation may need to be known in case you are exploring for looking at where the block might be, which might be leading to the portal hypertension, which is why we need to know this few variations with very small percentage variations, but we still need to know. Now this one, left gastric entering splenic, is in 24%, is in 1/4 of people. Right, so in a class of 150, that's what, 30-40 people. So that itself becomes a significant number, but usually it does not show up at all in pathology or in clinical medicine because it's doing its job efficiently. There is no mistake here. They're not called anomalies, they're called variations of the portal vein because they are quite within normal limits and they do the function efficiently, even if there is a change in where exactly they join. Similarly, inferior mesenteric here, inferior mesenteric is joining like a trifurcation, like 3 tributaries forming a portal. Here it is a tributary to the superior mesenteric. So both of these or all of these can happen. Anomalies is where some probable problem can occur because of that change, whatever the change is. So where the portal vein is anterior to the head of the pancreas and the first part of the duodenum, it is much more exposed. It is still retroperitoneal in its location, but it will have to come and become intraperitoneal from here to here because it is in the free margin of the lesser omentum. So that change over at some point, if the surgeon is not aware, they may nick it if they're not careful, if they're trying to get at the pancreas or the duodenum for whatever reason and are not aware that this anomaly is possible. Again, if the portal vein enters the inferior vena cava directly without getting into the liver at all, there will be an enlargement of the hepatic arteries. This is a rare one and we'll figure out how that works later, but this is one of the anomalies possible where portal vein enters the inferior vena cava directly. A pulmonary vein, again rare for a lung vein to not enter into the zygosystem but to come beneath the diaphragm and to enter into the portal vein, rare anomaly. There won't be any problem, it is only deoxygenated blood which is entering into the liver first before getting back to the heart. But that is the way. The thing to remember is your pulmonary veins are bringing oxygenated blood. Yes, so that would be a mixture in the portal venous system. Again, this is rare. I don't even know how compatible with life that is, but this anomaly exists, and you can have a congenital stricture. This is probably more commonly seen where in the newborn baby or even before birth, the stricture of the portal vein does not matter so much because the baby's digestive system is not doing any digestion. But once the newborn starts taking an oral feed and blood needs to get into the liver, carrying the absorbed nutrients, it won't be able to, and then there will be a dilatation of the portal system and a lack of nourishment for the baby and a consequent hypertension and so on in the portal system. So you have to just be aware of all this. This does not impact today's class, but we must aware that portal vein can have these variations and these anomalies. Now this is what you must have seen yesterday, where you are seeing the tributaries as they are normally seen. So we have the gastric ones, you have the pancreaticoduodenal ones directly, you have a cystic one here. This is mapping the whole territory which is bringing in blood. So you have the entire ascending colon, the right colic vessels. Transverse has been cut, but you have the middle colic vessels, and then you have the descending colon, left colic vessels. All of them will come and become tributaries back to the portal system. This would be the inferior mesenteric system, bringing it to splenic vein. This would be the superior mesenteric system, coming and joining here. The spleen itself is taking some gastric vessels, some gastropolyp vessels, and coming behind the pancreas. From here where it starts, after some course of the portal, it's taking directly the gastric system and one posterior superior pancreaticoduodenal vein. Apart from this, there is a ligamentum teres here right? This one, which is in the folds of the falciform ligament. Some veins from the anterior body wall. We have seen that as caput medusae in previous classes, where I talked about the umbilicus. So some veins draining the anterior abdominal wall go via this ligamentum teres and become a tributary to the portal system. Then there is a bare area of liver here between the diverging flaps of peritoneal folds, where it is right under the diaphragm. So that area drains via the phrenic, the diaphragmatic veins, into the azygos system, but also into the portal system. So those are again two areas where you have it's like a watershed, blood flowing away in two directions into two different venous systems. And here you can't see it, but there are body wall veins here in the paracolic gutters, where you have the posterior body wall systemic veins draining into the inferior vena cava system, which have a little bit of anastomosis with the vessels which are draining away into the superior and inferior mesenteric systems, particularly inferior mesenteric. So where are the areas which are significant for portocaval anastomosis? So we saw blue is blood from superior mesenteric, purple is blood from inferior mesenteric and splenic. It's like two streams, it's described as two streams here. And then you have the mixture obviously, and then you have the portal vein dividing into its left and right hepatic branches. So here, where you have esophageal veins is area one, where you have the portocaval anastomosis, where the lowest part of the esophagus, just before the stomach starts, the part which is transiting through the hiatus, esophageal hiatus of the diaphragm, that has an area that the wall, you remember, tunica intima, media externa. So the mucosa, submucosa, muscularis externa, and the serosa, right? Tunicas are the names we give for the walls of blood vessels. I'm looking at the wall of the esophagus. So at that wall of the esophagus, in the submucous region, there will be some venous radicals. Some of them are going away into the azygos system, esophageal veins draining upward, and a few of them are coming into and becoming tributaries to the left gastric artery along with this. This is the left gastric artery. So one is becoming a tributary to left gastric artery. Then two is, this is supposed to be an umbilicus, which is away on the body wall, but you get some paraumbilical veins also becoming tributaries via the paraumbilical veins becoming tributaries via the ligamentum teres, like I had mentioned before. Then three, where is three? Yeah, three is rectal veins. Now, just at the beginning is the esophagus, at the ending is the rectum, and rectum will become anus. Anus is body wall. So anus and lowest part of the rectum will be getting systemic venous drainage, which has to somehow join the caval system. So it has to become a tributary to inferior vena cava. It will join the internal iliac vein. Whereas some vessels from the middle and upper 1/3 of the rectum. When we do rectum, you will revise this again. But from lowest 1/3 of rectum, it is going to systemic veins, and from middle and upper 1/3 of rectum, it is going into the inferior mesenteric system in continuity with this. So the middle and superior, it's not marked here, will go like this and become tributaries to the left and right superior rectal veins are tributaries of the inferior mesenteric system. So that is an important area which will show symptoms in the patient. So that is called the rectal area of portocaval anastomosis. And then you have the retroperitoneal veins, what I mentioned earlier. These, all the fours, are where body wall veins and thin radicals going into the superior and into the inferior mesenteric systems are communicating along the ascending and descending colons particularly. So all the fours are along the ascending and descending colons. Also here at the pancreas. Also here there may be some body wall veins at the posterior side. So these are the retroperitoneal veins which will form a thin area of multiple areas of thin anastomosis between caval and portal systems. Okay, so this is just to show you where is the caval system. Here is the azygos, which is where the esophageal vein is joining up, and the system here, the retroperitoneal veins, will come into inferior vena cava. It's not shown here, but okay, it's shown here. So you have this one going into inferior mesenteric system, and you have the light blue going off into the tributaries to inferior vena cava. Similarly, rectum, you have the lowest tributaries going to cable system and the higher tributaries, these two, going into the portal system, right? And here they're showing paraumbilical. So around the umbilicus, you have tributaries to the internal iliac, some tributaries to the common iliac, both of them on one side. The other side is tributaries going into the directly into the portal system to the left branch. Now the formative veins are the tributaries 1, 2, whereas when the portal ends, it's called left and right branch. So here you have the left branch which is taking the paraumbilical veins, just like right branch took the cystic vein. So these is the areas in which portocaval anastomosis exists. So what is the applied anatomy? What we see is that you've already seen this before, I'm just repeating it, but it's important because in your pattern of exam paper, this may come as a question all by itself. So then it's not enough for you to just launch into applied anatomy, but for you to explain the formation, what would happen in yesterday's class, and then build upon that on how it will manifest in a patient. So when the pressure in the portal vein is elevated for any reason, venous enlargement happens in these otherwise thin-walled channels, and that venous enlargement is called a varix. We saw this in lower limb. We said there were saphenous varices, right, where the great saphenous vein was thrown into tortuosities if it was getting blocked in the drainage of the lower limb. So like that, we can have venous enlargement in the portal system, and these varices tend to occur at the site of portosystemic anastomosis. These enlarged veins are given different names depending on where they are. So now we are coming into clinical terminology. These words are not used in anatomy so much because in normal health, in all these structures, vein is vein. We can only explain that it either goes into portal or into systemic drainage. But when these veins, especially when they are dilated, we give them different names. So when it's happening at the anorectal junction, we call them hemorrhoids, or in the common man's terminology, piles. So you have a dilatation, a submucous dilatation, like I explained, at the esophageal level. Same thing can happen at the rectal level. And that dilatation with stasis of blood in those little pockets is called hemorrhoids. Then at the esophageal end, we call them varices at the gastroesophageal junction. And at the umbilicus, there is a special name given called caput medusae, but this is nothing but varices, venous varices in the anterior abdominal wall, superficial venous drainage. This is not the drainage of the deeper muscle, not the recti or the obliques. This is only in the subcutaneous region where you have the superficial venous drainage. Now, if there's going to be a area of hypertension in the portal system, these paraumbilical veins will not be able to drain into the portal system. A high pressure system does not allow anything to drain into it. So it will stop the paraumbilical veins from draining into itself. So the blood flow will be backward, and via these dilatations, it will try to flow into some body wall vein, right? And enter either the superficial epigastric or something, try to enter the femoral system, which is why it ends up looking like a radial bluish vessel, tortuous, prominent raised vessels under the skin. In fair skinned people, very easy to make out. In darker skinned people, you don't see the skin color change, but you will see the raised, the texture, the skin will be raised because of the increase in size or dimension of the underlying veins. And then, because it looks like the head of a medusa, it was called the caput medusae. So this is a typical sign which we will look for if we are suspecting a cirrhosis of the liver. Even if you are not suspecting, the patient himself or herself may complain of it, or the patient may come with a very enlarged bloated abdominal wall because the patient will also be retaining more amount of fluid in the peritoneal cavity, which also won't be able to drain away. Even the lymphatic drainage will be compromised. That distended abdomen, when you look at it, it will appear to have these venous pathways very clearly outlined under the skin, and we will call it caput medusae, and it is a diagnostic feature or a sign from the patient when we are looking at a condition of portal hypertension. In this case, labeled here is one cause, only one cause, which is called cirrhosis of the liver, which happens due to many reasons, but it's a very common, the commonest cause for this kind of appearance would be cirrhosis of the liver. Now we've done histology of the liver, so I want you to at this point recollect what we talked about, those hexagonal hepatic lobules, and how the vein portal triads are there at the corners, and how they're draining away blood, how blood is emptying into the sinusoids and draining towards the central vein, which goes into the hepatic venous drainage system. Now, so a whole bunch of sinusoids separate or exist between the portal venous blood falling into the sinusoids and the hepatic vein taking away that blood from the liver to become hepatic vein, which becomes tributary to the inferior vena cava anyway. But that gap between portal blood opening into the sinusoid and hepatic venous blood taking it away, that area, if there is any mismatch, any difficulty in the circulation at that area because of the disease of hepatocytes, because of a block, because of a bleed, because of a trauma, because of a tumor, then that situation doesn't allow the portal venous blood to be drained away, and there'll be a back pressure in the portal venous system. So if there is a hepatocyte issue for whatever reason, there will likely to be a portal venous hypertension. So the way liver responds could be as an immune response and inflammation, could be development of scar tissue, fibrosis of that reticular tissue which we saw in between cells, could be cirrhosis. I just wanted to show you this, and what cirrhosis is that the hepatocytes are getting destroyed and new hepatocytes are not forming to replace them but are being replaced by scar tissue. Cirrus, the Greek root is stone, stony hard. The liver becomes hard because it's soft pliable or firm pliable organic parenchymatous tissue is replaced by the fibrous tissue, which is of no use. It can't do hepatocyte function. So liver function will come down and liver texture will change to hard. Hepatocellular carcinoma is one type of liver cancer which can also initiate this kind of a process. On the surface, a healthy liver looks smooth and shiny and reddish purple. In hepatitis, there will be some amount of surface changes. In liver cancer, there will be stony, hard change and blebs of, surface projections, which are tumors jutting out. But it need not be like that. It could be a localized tumor in one part. But a localized situation, a tumor or a bleed or a cyst, will not give rise to a generalized liver hypertension or a cirrhotic change. Cirrhosis tends to be a more generic or widespread pathologic process which spreads from one hepatocyte to another and sequentially and aggressively destroys tissue. That is what we have to be careful of, and that is usually not happening very acutely. It can happen in some kinds of poisoning, but more often it happens in a chronic kind of a insult to the liver, a metabolic insult in the things you consume, or either it could be food such as alcohol, or it could be medication, or it could be some metabolic disturbance in your body which is delivering difficult to manage molecules to the liver over a long period of time in high doses. That's rarer. Most commonly known cause of cirrhosis is alcoholism. So, consuming alcohol over long periods of time slowly degenerates the cells, and at some point, a cirrhosis would arise. There would be stages before cirrhosis come. There'll be fatty degeneration. There'll be 5 or 6 stages. You learn all about it in next year. But do remember that cirrhosis is the most common cause where we can have sufficient liver damage for it to cause a difficulty for the portal venous system to empty into the liver. Therefore, a back pressure. Therefore, all the portocaval anastomosis will open up. So, I just want to spend a little more time on this. Just to familiarize you with the terminology. You don't have to write down all of this, but just understand why portal hypertension should happen in the first place. Now, systemic hypertension, when it happens in the caval systems, is usually an arterial phenomenon, right? The arteries, the tunica media have become tighter. They are providing a lot more resistance to the flow of blood, and therefore your BPS, your 120/80 has become higher. Either the heart is pumping harder, which is why the systolic will raise, or your peripheral vascular resistance has raised, which is why your diastolic will raise. So that's a completely different phenomenon. Here we're looking at a venous hypertension. So a portal hypertension is where an otherwise thin-walled, low-pressure portal vein is showing high pressure, and that's largely because the volume inside it is not able to empty. That is a common and common sense way to derive it. Why would there be high pressure in an otherwise low pressure venous system? How we classify the causes of portal hypertension is we can call it, because we remember sinusoids, that's why I mentioned that and reminded you. It can be pre-sinusoidal problem, a sinusoidal problem, or a post-sinusoidal problem. It can be extrahepatic cause or intrahepatic cause. This is the one way to divide. But what we usually do, and which is easier to remember and understand, is suprahepatic, intrahepatic, and infrahepatic. Suprahepatic means the blood is not able to flow out. There's an outflow obstruction. This may happen because of a right-sided heart failure, commonly, a constrictive pericarditis. And usually the portal hypertension will also show, and there will be a systemic caval hypertension also. So these are causes outside of the liver but upstream to the liver. This is like the portal vein has emptied into the liver, and the liver is now to take it away from hepatic veins into inferior vena cava. There is a block. Why inferior vena cava is not able to empty? Because the right-sided heart failure. The heart is not receiving blood. That back pressure will flow into the portal system. It's long-winded, long distance hypertension. So heart issues, heart failure, pericarditis, and because the heart issues, the caval system, the inferior as well as the superior vena cava are not able to empty. So there will be backflow signs and symptoms which you can pick up from the superior caval system also. So we are not worried about this so much. We will look at that later, though we finished thorax. Once we look at the heart and we look at the vessels, you'll get a better idea of how it happens. Intrahepatic causes are the most common, 90% of cases, where cirrhosis, which I mentioned, is common, but other kinds of intrahepatic issues can happen, such as what happens in rarely in children. They have inborn errors of liver metabolism, which can give rise to a portal hypertension. There'll be in pathology, when you put it under a slide, under a microscope, you'll have typical findings if there are intrahepatic causes of portal hypertension. So you have the diseased liver, in this case, liver cirrhosis. I don't know if you can read the labeling. In this case, due to schistosomiasis, something like a parasitic infestation, which happens in some countries. And the liver is full of these cysts of little parasites, and therefore its active tissue is much reduced, and it is causing a pressure. It's not allowing the venous circulation to proceed through the sinusoids and out, and therefore you have a back pressure, and then you have an opening up of the esophageal varices. You also have a back pressure into the spleen, so you'll have a markedly enlarged spleen. So if the liver itself, the liver tissue, the liver parenchyma is offering resistance, the spleen will show marked enlargement. The incoming blood is half at least is from the spleen, isn't it? Right? And back pressures will go and open up the portocaval channels also. Infrahepatic causes is the block is before the portal vein has entered into the liver itself. Infra, underneath, beneath, inferior to the hepatic region. So here the spleen is even more distally, even more enlarged, because obviously the block is from spleen, superior mesenteric, inferior mesenteric towards liver. So there's an obstruction of the extrahepatic portal system. This may be due to a thrombosis. You can see a blood clot here, a blood clot occupying the portal vein. If this one seems to be a long clot, it's in the splenic as well as in the superior mesenteric veins. It could be because of a cavernous transformation of the portal vein, rare. It could be because of a tumor or an infection or a compression somewhere here before the portal vein enters into the liver, in which case the liver won't show any signs of any change. Even if you do a ultrasound abdomen, or you do any hepatic tests, or you do any metabolic tests for liver function, I think the liver shows healthy functioning, but there will be downstream blockage effects, particularly huge enlargement of the spleen, and pathological anatomical findings if you're going to do any investigations. So the spleen is only moderately enlarged in the suprahepatic causes, more in intrahepatic, and most enlarged in the infrahepatic causes of portal hypertension. So what happens? This is the rectum part. I want to talk about it before we come here. So we have, you all haven't done gross anatomy of the rectum, but essentially it's a muscular tube, right? Just like any other part of the gut. And we have this circular transverse section of the rectum, and we are seeing again mucosa, submucosa, muscularis, and there will be a adventitia outside. So under the in the mucosa there will be a plexus of thin-walled veins. Here we are seeing the same kind of phenomenon but in the esophageal wall. So it is similar whether it is esophageal end or rectal end. The structure is similar. Here what they've done is they've looking at it from inside. You peeled off the mucosa. What you're seeing is a rich plexus of venous radicals. When you see the gross organs, esophagus and rectum, we can try to see if we open it out, we'll try to see if this is what it looks like. In normal health, it won't look like this. They won't be dilated and visible. This is only when they've been opened up because of high pressure coming into it. So this submucous venous plexus will form esophageal varices if there is portal hypertension. Once they are like this, if the mucosa was in place, it would be raised. See, you can see it's raised like that because it's not forming a smooth round outline, but it is raised into the lumen. And if, for example, in the rectum there's a hard feces here, there's a constipation in hard feces, it would rub against this raised mucosa and there may be an abrasion, in which case the thin venous vessel immediately under mucosa may tear. It may get cut through and then it will bleed into the rectum. So in the case of rectum, it will cause blood in the feces, right? In the case of the esophagus, it will cause blood into the contents of the esophageal lumen, which will go into the stomach. The trauma in the esophagus is likely again because we may not be consuming completely softened and liquefied food. A semi-solid bolus may cause a kind of an abrasion, or a little bit of incoordinated peristalsis where you're not swallowed correctly, you're talking and swallowing at the same time, something like that. Then that bolus arrives at the cardioesophageal junction without being soft enough. And if there is a localized trauma, you may damage these varices and they may bleed profusely. And once there's blood in the esophagus, the patient will have a blood-tinged vomitus, right? Hematemesis, it is called. The symptom is called vomiting of blood. And if it's fresh red blood, we have to really think in terms of an esophageal bleed. If it is an altered blood, it may have come from further down the track, such as a gastric bleed, because it has already been acted upon by stomach acids. It will change. The blood will change. The bleeding inside the gastric lumen will change in color and become reddish brown, and also further down the track. So if you're having a fresh bleed, it's likely to be more from the esophagus and more from a submucous venous plexus dilatation and damage. So these are the things we keep in mind, knowing the gross anatomy and the histology and the location of the vessels and the possibility of which one could have been a fresh bleed and which one could have been an old bleed, right? We come to a differential diagnosis of what could be the pathology which caused it. And if you're looking at an esophageal bleed, then one of the causes is definitely portal hypertension, opening up the esophageal varices. Need not always be only this. There can be other reasons for having fresh blood in the vomitus, but this is an important one. So you will ask the history and you'll do the examination based on the suspicion of this. Similarly, in the rectum, if the patient is saying, this is the wall of the rectum, this you're looking at it from the inside, again submucosa you're looking at, which means that the red mucous membrane has been peeled off to reveal that the veins are interconnected with each other with small dilatations. Now if you look at it in section, this is a vein and this is a vein. But this vein is draining away into the inferior rectal vein, which will form the systemic circulation. And the same plexus is also draining away upwards superiorly into a superior rectal vein, which is a tributary to the inferior mesenteric vein and therefore the portal system. Now this bulge into the mucosa can get excoriated by a hard feces, a hard stool, or any reason, and then it can bleed. Then you will have blood in the stool. The patient will complain of red fresh blood in the stool. Now one of the reasons it happens that this bulging can be a chronic phenomenon. It need not be only because of portal hypertension. This anastomosis exists even in normal life. It won't be so dilated in all of us, but in a few of us, for reasons we don't understand completely, in at least 3 positions in the transverse section of the rectum, there will be some some prominent anastomosis between the cable and the portal systems, and even in the absence of a portal hypertension, these things can become prominent, bulge into the lumen of the rectum, and sometimes become so big. This one becomes so big that it'll become bigger and bigger, and under gravity and under push of the feces will start hanging out of the anal verge and becoming visible outside, in which case that is called a hemorrhoid, a venous dilatation from the submucous layer, which is large enough to project into the lumen of the rectum and anal canal, and also sometimes outside the anal canal. So the patient can actually push it back. It's a soft bluish purple mass which the patient can push it back inside, and it may or may not have any problem. They usually have only a bleed if there is a hard feces, if they are constipated for any reason, or if there is a high intra-abdominal pressure for any reason. Then these, when they cough or they raise the intra-abdominal pressure for any reason, these hemorrhoids will pop out of the anal verge. Now, many patients tolerate this for many years, for decades, before they come to you with a complaint. And usually the complaint will be that they are seeing fresh blood in their stool, and they know that they have this problem for some years. Now, if it is not associated with any portal hypertension or any other pathology, but it's just a localized venous distension, in some individuals, for some reasons, they've let it grow for over a period of time, we can do a simple surgery, a hemorrhoidectomy, and close it. And this got nothing to do with metabolism. But hemorrhoids and per rectum bleeding is also an important sign of a portocable anastomosis opening up, and therefore we should examine for any reasons of portal hypertension in patients of this nature. This is just to show you how the esophageal varices work. You have a liver here which is cirrhotic, right? This is the diaphragm, this is the diaphragm, this is the esophagus becoming the stomach. You can see the inner lining of the stomach. So this is diagrammatic, just remember. But it has got these venous channels which are submucous in nature. They're not actually, this is a painting. In life it looks a lot more purple and not so very prominent. And the point is that these venous radicals are supposed to drain up via the azygos vein, and the lower ones will drain via the left gastric vein, right? So when they open up, if they are visible to you in an endoscopy, for example, like this, an esophagoscopy has been done, and at the cardia of the stomach, you're seeing these purplish things bulging out at you from under the mucosa. So they are actually under the mucosa, but their color is prominent. Mucosa is a thin, transparent, creamish color. So anything blue, purple will show up underneath it. And these are looking all right, and since they've not been cut through, they're not bleeding at the moment, but they're so vulnerable. Even the instrumentation can damage them, especially if they are under high pressure. So this is not commonly seen except in portal hypertension. This is not a common phenomenon, right? So this just to show you what the anatomy is like. This is a long coronal section. This is an endoscopic view. This is if you are doing a contrast radiography of the esophagus. You can see these are the vertebrae. These are the ribs. So you're looking at the esophagus in the thorax, right? And it does not seem to be filling smoothly and continuously, right? This is a smooth filling. We've asked the patient to swallow a radiolucent, a radio opaque dye, a medium, a barium sulfate solution. It's called a barium swallow. When you ask the patient to swallow, it fills the esophagus and you take the radiograph. And if it's not filling properly, it could be because the lumen is being disturbed. If the lumen is not continuous, smooth, cylindrical lumen, but is being disturbed by these projections from the side. So that would be the radiographic look of such a esophageal larynx. And if you do a splenogram, this is an angiogram. You've introduced dye into the portal venous system somehow. Homework. How can we introduce a radiopaque dye only into the portal venous system, not into, so it does not enter the systemic? Because when it enters the systemic circulation, it will confuse which part of the tree is being filled up. So in this case, what is happening is the splenic vein vessels have been filled up. The spleen, they're trying to check whether how much the spleen is dilated and how much spleen vasculature is impacted, and whether there is any block in it, which may be one of the infrahepatic causes of portal hypertension. So there is a range of investigations we do depending on the suspicion of what is happening, which is brought to us according to the presentation, what the patient comes to us, and you have to work backward and figure out what is happening inside and confirm it with your investigation and then go for the treatment. Alright, so this is the applied anatomy or the surgical anatomy of portocaval anastomosis. You have to be able to write the points, as many as you remember, but all the sites of the anastomosis and what could be their manifestations. Now, of all the sites mentioned, the ones which show clinical manifestations are esophagus and rectum. And is there anything else we saw? Just go back to the various sites, and caput medusae are the umbilicus. These are the main ones which will show up in patients, but there are also retroperitoneal, paraumbilical regions. So if you remember these, I think, and bare area of liver, these 6 if you remember, that should be good enough. If there are any doubts in your further reading, please pass them on to me, and we can close the class for now. All right, we have a few more minutes. Next class again I'll be continuing histology. To the best of my knowledge, I'm not getting any feedback, and I think none of the teachers are getting much feedback from the students. It's a good idea if you all can message or mail us, or the chat is a good way to raise questions or queries. Or you can send your queries to your class representative, and the lady or the gent, they can pass it on to us. Just remember that because I can't interact with you in the classroom, it doesn't mean that you'll, just let your doubts slide. Because after you all come back, there won't be any time to catch up with the huge amount that we would have covered. So, class by class, please send us your feedback, especially if you all got any doubts. Okay, so I'll see you in the next class. Bye.